So my name's Sara James and I'm a clinical specialist physiotherapist at Bevan University Health Board, and I want to talk to you today about the innovative project that we've been running during COVID-19, which is named in short the Physio Diaries. And just to elaborate a little bit more, it is actually a project whereby we've used co-production to aid post-COVID-19 outpatient service design. So this is part of a multi-phasal piece of work, and so I'm just going to really quickly run through the first phase of the work. So the first phase was quite literally inductive in nature. We just wanted to go out back in the first phase of the pandemic to find out how physiotherapy staff were managing and how their experiences were of working during COVID-19 and their future thoughts moving forwards at that point. As a result of that phase of work, there were many unintended themes that we didn't expect to find regarding system change and how the future should look for physiotherapy. And so as a result of that work, we moved on to more deductive work, so further exploring some of the themes that we found from the first piece of work. And this project was aiming to encapsulate one of the themes surrounding sort of telehealth and musculoskeletal outpatient physiotherapy services in Bevan University Health Board moving forward. So our main aim then is to explore experiences of patients whom have received and physiotherapists whom have delivered MSK outpatient physiotherapy during COVID-19 and how this has shaped their views for a future service. And the rationale underpinning this is to use lived experience to gain insight and learn the vital lessons needed to be learned from this pandemic, to actively involve stakeholders in system change and to co-produce a valuable and meaningful future physiotherapy service. So why? So what we know from sort of the current research and past pandemic research and crises research is that insight into sort of how that's gone for people is achieved through learning about their experiences, and there's a need to learn now in order to apply findings both within further phases of this pandemic and in future crises. So the first part of this work was around sort of healthcare worker impacts, because we know that pandemics heavily impact healthcare workers, and there was a need to do it on the ground as it was happening because of emergent nature of COVID-19. We also know that crises and pandemics can drive positive change, and there are lots of examples of this in the research. And we also know that the NHS needed to change prior to COVID-19, and since COVID-19's arrival, this need is amplified. And finally, we also know that co-production and stakeholder involvement in decision making is not only a desire of sort of several big sort of government drivers within Wales and within sort of work ethos, but also it's a legal obligation as per the Future Wellbeing of Generations Act 2015. And so we have a duty in this work to prosper. So how? So qualitative. So exploring lived experience is best done in a qualitative way, and qualitative research is well known for its utility in producing quality-rich information, and it allows us to explore the what, but not just the what, but the how. And the reason why it lags behind, we don't see it as much, especially in previous pandemics, is because there's a thought that it's difficult to draw meaningful conclusions and communicate those meaningful conclusions to policyholders. There's a worry for negative emotions as a result of methodology, and there's an infection control consideration when going out and doing this methodology during pandemics. However, early research into COVID-19 rapid reviews have shown that actually qualitative methodology also provides an outlet for participants and allows them to offload and thus become more resilient. And actually digital innovation has been a really good answer to the infection control risk. So just through virtual meetings, for example, and the ability to record, we're able to capture information in a different way. And then in terms of communicating to policyholders, there is analysis called framework analysis that is able to grasp something that's going on the ground and then analyse that to provide a contextual explanation and then present that in a systematic way. And it's really sort of favoured by social policy research, but also healthcare research increasingly. And there is already a theoretical model for COVID-19 and creating meaningful change produced by the Royal Society of Arts. So we were able to use a theoretical model throughout to be able to map our analysis onto. So a really quick summary about phase one. So that was when we went out to explore physiotherapy staff experiences, and it was very, very open, and we just explored sort of how they were doing and their thoughts moving forwards. We put that into a framework analysis and we reported upon it, and the outcome was a bespoke set of recommendations for the future of physiotherapy, driven by staff reflections essentially, and their conversion to action points. For this piece of work, we wanted to focus on, I'm a clinical specialist physiotherapist in outpatients, so my stance here was going to be outpatients for this part of the work. So we wanted to pull in on telehealth and e-health as an only option, because they came up, so people didn't want e-health as an only option, but they did want telehealth and e-health to prosper, so we needed to look at that. So that's converted into what would an optimal physiotherapy outpatient service look like to you. We also, for the second part of the work, added in patients as additional stakeholders, because obviously they're really focal to the service. So we did this via semi-structured interviews with improved utility as a result of spreading and scaling this research and this work, and the improvement in basically my ability to be able to do interviews. They were captured via video, and this was threefold. For infection control reasons, digital innovation, so ways of sort of delivering messages via video. It's been a really good way of engaging people, and I was also inspired by Swansea Bay's digital patient stories work, whereby lessons have been learned by just listening to people and recording them, and then they've been delivered in that way. We found we were able to map the results onto 3 different frameworks, the last one being the most important, but I'm just going to quickly run through the physiotherapist insight. So physiotherapists wanted to end the belief that telehealth is equivalent to usual care, which is really interesting, because prior to COVID-19 there was a belief that quantitative data would support that actually telehealth is equivalent to usual care, when actually what we're finding on the ground is not, but it's kind of getting lost in all of the excitement of telehealth. COVID-19 restrictions, for example, things like filling in risk assessments, desk-based work, not sort of having a staff sort of morale and teamwork ethos because of telehealth and sitting behind a computer. They wanted to amplify good practices that they've observed both within physiotherapy and within the wider sort of world. So we've done lots of spread and scale as a result of the need to do things quickly, and actually they don't want to go back to not doing that. They want to continue to spread and scale good projects and good examples of practice. They want to be able to collaborate with both professionals and patients, and they want patients to have a choice and ownership of their condition and their healthcare, to include how they access physiotherapy. And most importantly, they want a voice. Clinicians want to be able to have a voice in system change. They've had an experience whereby they have been able to contribute to system change because we've had the time to do it, and they don't want that to stop at this point. They want to let go as face-to-face as an only option. So before COVID-19, that was our only option, and actually that's because we knew no different, but they don't think that's a good way to go, a good practice to go back to, and they don't want to go back to sort of rigid templates with half-hour appointments and picket line work. They want more flexibility and more sort of ownership and more control over what they're doing with their patients, because they are the people in the know, and they want to restart full service provision. Patients, quite similarly in some ways, they want to end at current limited service and COVID-19 restrictions. So quite similarly, they want to be able to get back to physio as they would expect to receive it. They would like a clinician that listens. So what they've sort of honed in on is over the telephone, they don't, without the face-to-face contact, they don't feel that they're always being listened to, which is interesting. But they find where they have been listened to, that the experience has been better. So they want that to amplify. They would like a hybrid model. So they're not saying that they don't want telehealth, and they're not saying that they only want telehealth, but they actually would like to be able to pick and choose as and when they feel fit. And there are some patients that don't want it at all, and there are some patients that only want telehealth. So there needs to be a sort of hybrid model amongst that collective voice. And they would like, again, to have that choice and in twofold, how they access physiotherapy and how they receive their physiotherapy. So that's really important. Interestingly, this was really interesting find, that letting go, they want not to go back to long waiting for physio. So they don't want to wait for 13 weeks before they get to physio. They want to be able to access that, because sometimes they've sort of said that they might only need advice. So they want different ways of getting to us. And they also wanted to break sort of the stance of hands-off physiotherapy, i.e. exercise therapy and advice, and they want to at least know why manual therapy isn't being considered, and that's something that I wasn't aware was even a perception. So that's something that we can explore further moving forwards. And again, they also want to start full service provision. So we were able to sort of combine both of those and then put them on top of each other and be able to provide a collective insight about how outpatient physiotherapy and musculoskeletal services should look in the future. And so we shouldn't, although we brought in telehealth as an only option during COVID-19, we shouldn't use that as an only option moving forward. That should stop. Instead, we should have a hybrid model where a patient is given choice, aided by a clinician that listens, using resources to facilitate that interaction, and that could include telehealth. They want improved access to physiotherapy to include the timeliness of that response. They want to let go of the long waits, which complements the aforementioned, and they want to break the barriers of traditional care to include just face-to-face appointments, but also some of the treatment choices that we have chosen. And they also want to start full service provision. So whilst that's wonderful to know, you know, a lot of that we kind of may have already questioned. I'll come on to that in a little bit. I thought it was really important to hone in on the quality of the information. So these are just two representative verbatims of different patients. The first one demonstrates not only are patients thinking about what they want, they're also thinking about how they would like to achieve that. So for example, this person is talking about using virtual technology to aid waiting time. So just to get to somebody quickly, use virtual technology, but then with the expectation they have a face-to-face at some point to have the full assessment. So that was really interesting. Actually, I really like that idea, and it's something we could actually look at. And the second one was a really interesting one, because what this sort of encapsulates is the lack of awareness of what we do. So for me to read this as a physiotherapist, actually we do have these things in our toolkit, and quite evidently we're not utilising them enough, and there isn't actually a reason for that, because things like manual therapy do exist in national guidelines. So we do need to sort of think about, number one, how we are providing our care, but number two, what we are doing to provide insight to what it is we do to patients and professionals, I suppose. So this is just sort of just shows you that we can pull the so what from raw data, essentially. So what? So from here, so we have our bespoke recommendations both for physiotherapy and now musculoskeletal outpatient physiotherapy. Some of this work is already happening without my help. So we're already thinking about how to triage and how to get to people quicker and how to provide a hybrid model. However, what we have done through doing this work is challenge the assumptions. So anything that's happened to this date has been based on assumptions, because we haven't done any engagement events. However, this work will add that insight and challenge the assumptions that we have, and yes, affirm the thoughts that we have as well in some cases. It's a simple and timely way of doing things. I've done this twice in a year now, and so it just shows how quickly you can get things done, and it demonstrates a really quick and simple way of getting data and analysing it and providing meaningful conclusions. It aligns with many sort of policies, a healthier Wales, looking forward together, talking about sort of, you know, engaged workforces and co-production, stakeholder involvement. And in terms of value, whilst I can't sit here and talk about cost effectiveness, because this isn't that sort of type of work, what I can do is sort of flip it. If we didn't do work like this, then we would have lots of things we would want to work on, maybe not enough stuff to do it, and productivity would be lost. By doing this work, what we've aligned is some priorities of things that we need to look at now that both clinicians and patients would like to see, and we can work on those and do those well. And actually in doing so, not only provide productivity, but hopefully improve that patient journey in the long term. So hopefully, yeah, it's provided value in a different sort of way. Key outcomes, so I've just done a full circle. So we've managed to explore experiences of patients and physiotherapists who have received and delivered respectively MSK outpatient physiotherapy during COVID-19, and we've worked at how this has shaped their views for future service. We have used lived experience to learn the lessons. We've actively involved our stakeholders, and we've co-produced a valuable and meaningful future physiotherapy service. Barriers for this work. It's a fast evolving pandemic with many phases, and this work only represents this part of this pandemic, and you may well get different data based upon the phase of the pandemic, and that was highlighted by the first piece of work when reflections weren't becoming action points, and part of that might be to do with reflection on action, reflection in action, experience of reflective practice, but it also might be because people are not thinking about it and they're just working and they're just doing what they should be on the ground, because they're very resilient and focused. However, the methodology does support quick data collection and collateral analysis, so this could just be done at those phases, and we've shown that and how that can happen. Buy-in. So I do feel uncomfortable up against sort of big projects with lots of cost savings and big validated outcome measures. It's not that type of work. But what I hope that we've managed to show and demonstrate through this is that we've managed to sort of challenge the unease of conducting qualitative work within healthcare. It is a really wide known acceptance that we don't do it enough despite its utility. So hopefully that is something that will counteract that. And I thought about not putting this in, but I thought I have the opportunity to have a platform. I worry that we will revert. I worry about reverting back to old practice. The irony of all this is, at the start of this pandemic, I had the time to do this work, which is why I've managed to do so much. And towards the end and the writing up, it's been much more difficult. I've been trying to juggle a million things. I've been working long hours, and job satisfaction has been less. So I really worry for that. However, if I don't say that, then I can't stand up for what we believe in, and nobody will know. I have to be that voice to tell people that we need the time to be able to do things well. Yes, and so in terms of facilitators, which I think is really important to hone in on, and I've had quite a lot of imposter syndrome with regards to this project. Has it been good enough? Has it been, has it got a big enough message? Does it stand up against all the big projects? However, every time I've had that, I've had a good leader that's backed me when I haven't backed myself. And so actually, I've taken a lot from leadership I've taken a lot about leadership from this. I've had people that have wanted to be heard. So the patients and physiotherapists alike have wanted to tell me their stories and wanted to contribute. And I think that's the beauty of this work, is that actually it's only work because you've got people that want to get involved, and that's really important. And as I said, I did have time at one point in time to be able to really sort of get my teeth into this and the pandemic for me has been providing me with a unique opportunity to sort of stop and pause about what it is we're trying to achieve, or what I would like to do and how I'd like to contribute to service development in my directorate. So what now? So this is just a sort of a spider diagram of how this has snowballed from a very small idea, and the small idea being, let's just go and find out how the physios are doing. I've been presenting at a couple of different sort of events, the the research community of practice, employee wellbeing service. The first stage is written up and is ready to go to be submitted for dissertation. I'm going to present the themes to our executive team. I hope that it informs the decision making, and I'm just hoping that the use of these platforms is going to gauge interest for other sort of directorates and other professions to use this sort of methodology to find out what's been going on during COVID-19 and how we can learn from it, both within physiotherapy, within allied health professional networks, and then wider in Iron Bevan University Health Board, and even wider again if it goes that far. We will see. Finally, and last but not least, sort of my experience as a Bevan Exemplar. So Bevan Exemplar for me was the epiphany I didn't know I needed. I'm a clinical specialist physiotherapist, and I thought that was going to be my life. I thought that that's all I had to know, was how to be a really good physiotherapist, and what that meant was being able to treat my patients well and provide good treatment. However, that's just a drop in the ocean. That's what I've learned from the Bevan Exemplars. There is so much more to really value-based healthcare than just providing that care on the ground. I've learned about quality improvement, innovation, networking has been amazing. I've grown in confidence like tenfold. And so for me, I implore anybody with an idea that wants to be heard to consider this programme. And I just thank Bevan Commission for my new perspective, because it's almost provided me with a new sort of direction of travel and a new vision for my career and my personal and professional life. So I really thank you, Bevan Commission.
We will now have a Q&A discussion. How will you demonstrate value for cost in this project?
This work is the sort of first type of work I've done like this. So I kind of learned on the ground, and especially in terms of like sort of cost savings and things, I didn't really have any awareness or any involvement in any of that before this point. And I did really struggle with this at one point. I think I think that the way I think I probably have to collaborate more with sort of management and be more aware of what's going on above the ground to know how I can translate it more into sort of cost savings and things. But at the moment, I'm just trying to say if we so for example, I use one of the themes from the first piece of work. So the collaboration, so all the physios, inpatients, outpatients, clinical, non-clinical, operational, managerial, they all found collaboration on the ground really helpful and effective, and the reason being is that it provided holistic patient care. So I think probably what I'd have to do then as a result of that is to prove the benefits of providing that holistic patient care, so in the patient journey, and then sort of I think I need probably to do more deductive work around the themes to be able to then get the cost savings for each sort of sub theme, if that makes sense. So it's going to be more sort of longitudinal study, I think. And time was the other one that I'm struggling with. So time, that was such a strong theme. Like physios have had more time to sort of think, to be involved in the service development, to be able to spend with patients, and that some of that's already nationally known. So like stroke guidelines and intensive care guidelines already say that actually more time with patients does help their outcomes. That already exists, and we're just sort of adding an insight for that. However, in terms of like sort of time for projects and time for service development, again, I would need to sort of do more deductive work in longitudinal study in terms and prove how that's going to revert to either an improved patient outcome or improved job satisfaction and things like that. I think it's just this is in its infancy, and it just needs to. I need to work. Yeah, it's a bigger project than I ever anticipated. Yeah.
What are your views on challenging patient assumptions?
When I did the second round of work, I was able to make a more deductive interview schedule. So I did add a question in at the start and ask them if they had previous physiotherapy. Before COVID, and I think we did for this piece of work, we looked at 10 patients, and I think like 6 of them had already had physio before, so they could make a direct comparison at our previous service and the COVID service. So they were able to say, so the big things, and I wasn't expecting this to come up, but the big things that came up were, before we really liked coming in face to face, however we didn't like waiting such a long time to get to it, and at the moment we really like being able to get to you quicker, but actually over the phone, and particularly over the phone rather than over attend anyway, a virtual platform, over the phone is it's better than nothing at the moment, but actually it isn't really what we expect physio to look like, sort of thing. But they were really, so that wasn't just sort of resistance to change, because they were really good insights into why the phone isn't as good. So one of the quotes that stuck in my head was a patient that told me that, she did over the phone, and then she did a virtual, and then she ended up coming in face to face. She said over the phone, I just felt like over video compared to over the phone, I felt like you cared more. So because I could see you and I could see that you were engaged in the conversation, I felt like somebody was listening to me. So that I think that they were able to, it seemed that people were able to draw on past and current experiences to make a deduction of what it should look like in the future. And I expected everyone to say, let's go back to face to face. That's what I expected. So it's challenged my assumption, because that's not what they were saying. They were saying, actually, no, virtuals work quite well in some respects. However, to really get into my problem and to get to the bottom of it, actually, I think maybe seeing me once face to face would help. So it challenged my assumptions of what I thought they were going to say, and particularly with like manual therapy and things. That was a big shock for me, and that's got another whole sort of exploration opportunity, really, as to what do patients think physiotherapy is, and what do we think physiotherapy is as well.
Could you challenge patient assumptions more?
So I think we've started. I think that especially the second bit of work, I was able to probe more on things and explore sort of topics to a greater extent, and that was more because I was more comfortable with what I was doing more than anything, if I'm honest. I think that there's work to be done. I think that we need to challenge the big themes like time and collaboration, like why, so what's going on with this time things, why do you feel that you need more time, what do you think that's going to produce for you? So I think probably in short, no, we haven't done it radically enough, but what we do know is that we can use this methodology quite easily to do that, and I hope that this platform and this opportunity has demonstrated what you can do by asking a couple of questions and analysing the outcomes in a meaningful way. So yeah, I think there's scope to be more radical, but we've got the COVID-19 is a really unknown subject, so I think what we've managed to do is explore the bits that we need to look at more, if that makes sense.
Have you explored the whats and the whys behind the huge number of DNAs in physio from a patient perspective?
Only speaking from my own site at this moment in time, it's just something we probably need to look at a little bit, but so I work in Newport. In Newport, we are seeing, so we're giving them a phone call as like a first appointment at the moment, and lots of people are not answering the phones, so that goes down then. I'm really stringent about this, so I make sure that patient was aware of that phone call for a start, just based on the different ways that we allow them to know that they got an appointment. So I make sure that there is a true DNA and not a actually I wasn't aware of it, because that's not fair. It's not an equitable service. But also, I found that, so I'll explore that when they do answer the phone and they weren't expecting the appointment. I'll explore sort of like their commitment to it, and I think my sort of deduction from it is the commitment to answer a telephone call isn't equitable to the commitment to come into a department and engage in an intervention. I think answering a telephone call, like we have people in their cars trying to do objective assessments, which it can't happen, or like in their 10-minute breaks and things. And for some things it will work, but for like our traditional physiotherapy, whereby we sit there, we listen to patients, we've been lucky enough to be afforded the time to be able to listen to patients and really look and explore their problems and what that means to their function and things like that. It's not really the same. And I think that patients, they will answer their phones but not actually present, if that makes sense. So I don't think that it's perceived. I think the DNA rate is reflected by the fact that service, that service isn't perceived as the same as coming into a department, coming face to face. And there is an issue around whether they know about the appointment or not, because I'm noticing that a lot on the ground, but it really is, this is just raw sort of stuff. I'm just looking at my own caseload here when I'm talking about this. But this work needs to be done around it, I would suspect.